Hey everyone, hope you're having a great week. Today's little talk is on stage 2 pressure injury. Specifically, can stage 2 pressure injuries be associated with necrotic tissue or slough? Conventional teaching has been that there is no necrotic tissue or slough associated with stage 2 pressure injuries. We'll revisit this today with reference to some basic anatomy and some basic pathology. So let's first define necrosis. Necrosis is cell death, and cell death is essentially due to disruption of the membrane sodium-potassium ATPase pump. This leads to accumulation of intracellular sodium, swelling of the cell, and the organelles within the cell, such as nuclear swelling, leading to disruption of the cell membrane and lysis of the cell. That's in a nutshell a very simplistic view of cell necrosis. Etiology of necrosis: there are many causes of cell necrosis, including trauma, burn injury, toxins, systemic diseases, chemicals such as acids and alkalis, and even some medications. So necrosis is associated with many disease processes or external insults to the body. So any cell type can undergo necrosis. We have fat necrosis, muscle necrosis, bone necrosis, and in fact skin can be involved in necrosis with systemic diseases such as ecthyma gangrenosum due to infection by Pseudomonas, toxic epidermal necrolysis, or warfarin-induced skin necrosis. So we have any cell type involved in necrosis. Skin can undergo necrosis, and the fact that pressure or trauma can lead to cell necrosis. So three of these factors together should be enough to convince an individual that partial dermal injury can lead to partial dermal necrotic tissue, i.e. stage 2 pressure injury can be associated with non-viable tissue. However, there are some people who will still not be convinced. Now, as we have noted, excessive pressure can lead to cell necrosis. Now let's look at skin anatomy. We have the epidermis overlying a much thicker dermis which overlies the subcutaneous tissue. Now, skin is an organ made out of different tissue types. These tissue types include sweat glands such as eccrine sweat gland, sebaceous sweat glands. These are complex tissues that can undergo necrosis. Nerves, which can undergo necrosis. Blood vessels, which can undergo necrosis. So partial dermal injury can lead to necrosis of these tissues, i.e. accumulation of non-viable tissue in stage 2 pressure injury. Now, these arguments notwithstanding, let's look at debridement of necrotic tissues using topical products. In clinical practice, clinicians commonly use collagenases to debride non-viable tissues. Collagenases fragment denatured collagen fibers which are present in the extracellular matrix. Collagen, in addition to providing strength to the tissues, together with other extracellular components such as proteoglycans and glycosaminoglycans, helps to anchor the tissue cells together and to other components of the body. So if one breaks down this extracellular matrix, that should lead to debridement of non-viable tissue. Even though collagenases do not debride some of the main components of necrotic tissue, such as in adipose tissue, there's very little collagen. Majority of adipose tissue is fat cells, and collagenases do not debride fat cells, but they debride the few extracellular matrix collagen fibers, which helps in wound debridement. So we use collagenases to debride necrotic tissues. Now, on this slide here, on the right hand side, you can see extracellular matrix components of various organs and tissue types. And in tissues such as the muscle and tendons, collagen forms a significant amount of the dry weight, whereas in subcutaneous tissues there's very little collagen. But if you look at skin, there is a lot of collagen. Over 70% of skin is collagen. Over 70% of dermis is collagen. So are we now saying that we accept that if you have a full thickness skin injury, you can have denatured collagen, whereas if you have partial thickness skin injury, i.e. partial thickness dermal injury, you cannot have denatured collagen? That doesn't make any sense to me. So here is a depiction of partial dermal necrosis. The black represents necrotic dermis with non-viable epidermis overlying a healthy dermis. As one can see from this depiction, the necrotic area will involve complex tissues, including sweat glands, nerves, blood vessels. Necrosis of these complex tissues will lead to accumulation of non-viable tissue on top of uninjured dermis. Now, in certain regions of the body, it's easy to see how one can get partial dermal necrosis, such as on the back, where the dermis can be up to 8 millimeters thick. So if 4 millimeters of the dermis is injured and necrotic, that will lead to accumulation of non-viable tissue. In other regions of the body, where the dermis is much thinner, full thickness necrosis of the dermis, i.e. 2 millimeter necrosis of the dermis, will lead to exposure of the underlying subcutaneous tissue, and people will accept, yes, this is non-viable tissue because we can see fat, even though only 2 millimeters of dermis are involved in the necrotic process. Whereas on the back, you may have 4 millimeters of the dermis involved in the necrotic process, but still a partial thickness injury. So if we are going to accept 2 millimeter thickness injury to the dermis on certain anatomical regions of the body as leading to accumulation of necrotic tissue when the subcutaneous fat is exposed, then we should be able to accept 4 millimeter necrosis of the dermis on the back as leading to a layer of non-viable tissue on top of a relatively healthy dermis. Remember, in stage 3 pressure injury, it's just full thickness injury of the dermis with exposure of the underlying subcutaneous tissue. There need not to be any injury to the underlying subcutaneous tissue. So, yes, under certain circumstances, one can have necrotic tissue on top of a viable dermal layer. So to summarize, any cell type can undergo necrosis. Pressure injury can lead to cell necrosis. Collagen is a significant component of the dermis. We commonly use collagenases to debride necrotic tissue. So theoretically, one can say that you can use collagenases in partial thickness dermal injury. Now, not only collagen is denatured in chronic wounds, there are other extracellular matrix proteins which are also denatured or undergo necrosis. That's why you find enzymes such as elastases in the extracellular fluid, which degrade non-viable elastin. So wounds are far more complex than simply limited to one cell type or component of the extracellular matrix. We also know that in third-degree burns, full thickness necrosis or injury of the dermis leads to third-degree burns, whereas partial thickness dermal injury leads to second-degree burns. So we accept in burns that you can have partial thickness skin injury, i.e. partial accumulation of non-viable tissue in deep second-degree burns. In stage 3 injury, we know that there is full thickness necrosis of the dermis, with or without necrosis of the underlying subcutaneous tissue. So given all these factors, there is absolutely no reason why one cannot have accumulation of non-viable tissue in partial thickness pressure injury. It absolutely may. So as clinically observed, it is possible to have necrotic tissue on partially injured dermis, i.e. necrotic tissue associated with stage 2 pressure injuries. Many times I have debrided wounds on the heel and on the back. Once you finish debriding non-viable tissue, the base of the wound is still dermis, because the dermis in these regions is quite thick, in some cases even up to 1 centimeter thick. So you can have necrotic tissue on partially injured dermis. So one of the things I was thinking was, why would somebody make a blanket statement that stage 2 pressure injuries can never have necrotic tissue or non-viable tissue? Now, you can have stage 2 pressure injuries without necrotic tissue when it's very, very superficial, or you just get de-epithelialization of the epidermis. I think one of the reasons that it may have been accepted as such is because stage 2 pressure injuries can heal without formation of scar tissue. And stage 2 pressure injuries can epithelialize through migration of mesenchymal cells from the dermal papilla and from sweat glands. So you do have a partially injured dermis that can still undergo scarless healing, but that does not mean to say there was no necrotic tissue that has actually been debrided or has come to undergo autolytic debridement. The next question is, can eschars be associated with partial thickness dermal injuries? The answer is yes, under certain circumstances, or anatomical regions of the body where there is a thick layer of dermis, such as the heel or the back, for example. Partial necrosis, partial injury to the dermis, can lead to formation of a thin eschar. If the eschar is treated appropriately, after many weeks it will peel off. And what I have observed in clinical practice, when the eschar peels off, what one sees is a fully healed scarless wound, i.e. the eschar was overlying a partially injured dermis. Now, to date, Medicare does not accept that stage 2 pressure injuries can be associated with non-viable tissue. So I hope through this presentation I will encourage peer discussion. And I don't think there are many clinicians out there, or any clinicians out there, who will accept that eschars can be associated with partially injured dermis, simply because that's how they were taught. The eschars are associated with full thickness injuries, and they've come to accept that. Give you another example. We have guidelines that patients who are prone to pressure injuries should be turned every 2 hours. Well, where did the number 2 come from? The story I heard, and there may be variations of this out there, is that in Second World War in England, in a certain hospital, where they had patients who were prone to pressure injuries, 2 muscular guys, so to speak, were tasked with turning the patients. And what they did was they turned the patients, and once they completed their round around the hospital, it took them 2 hours, and then they started again. So it was a 2-hour turning period. And what people found was that reduced the incidence and the severity of pressure injuries. Well, it could have easily taken them 3 hours or 1.5 hours. But we have come to accept 2 hours in most cases as the gold standard. And there are other cases in medicine just like this. So never say never in clinical medicine. So I hope you enjoyed this short discussion. Probably controversial, but that's good. If you can encourage thought process and peer discussion, then that's good. Don't forget to subscribe to the channel, and if you enjoyed the discussion, like the video, and I'll see you soon. Bye for now.